1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's
300 please.
I'll keep you on again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
So picture this scenario for a second. Your patient was admitted, let's say, 2 days ago for a mild urosepsis.
Okay, pretty standard.
Right. They're sitting up in bed, they're talking to their family, completely hemodynamically stable. Off pressors, totally fine.
Doing great.
Yeah. But then 30 minutes later,
Yeah.
you walk in and they are completely locked in, like completely rigid, actively choking on their own saliva.
Terrifying.
And the thing is, they aren't dying of the sepsis. They are crashing because a single routine Parkinson's pill, I mean, a medication they've taken at home for 10 years was given half an hour late.
Wow. Yeah, it happens so fast.
It really does. In the neuro ICU, missing a schedule by minutes is just lethal. So today, we're taking a massive stack of medical literature on chronic and degenerative neurologic disorders. We're talking seizures, myasthenia gravis, MS, Parkinson's, ALS, Huntington's, and even primary headaches.
That is a lot of ground to cover.
It is, but we are tearing out the fluff. We are aggressively applying the 80-20 Pareto principle here.
Which means, we are exclusively hunting for that 20% of the pathophysiology and the pharmacology that dictates 80% of your bedside clinical results.
Exactly.
Because when these chronic neurologic patients cross the threshold into critical care, that margin for error effectively evaporates. I mean, we aren't focusing on how to manage their outpatient physical therapy. We are focusing on what is going to kill them in the next hour right in front of you.
Which is such a crucial mindset shift.
Yeah.
And that requires a fundamental change in how we approach the bedside.
Yeah.
We're looking at this strictly through the lens of an intensivist and a critical care nurse.
Right. The goal here is to elevate that clinical reasoning.
Yeah, we want you, the listener, standing there at the bedside, to connect the invisible cellular failures, the depleted neurotransmitters, the rogue autoantibodies. Connect that to the crashing apneic patient.
It's all about pattern recognition. It really is. And understanding the why behind the deterioration. You might be managing their pneumonia, sure, but their underlying neurologic disorder is a physiological landmine.
A total landmine.
And if you don't fully grasp the mechanisms of their disease, you will misinterpret the subtle warning signs of a secondary crash until it is, honestly, entirely too late to reverse it.
So, we're going to bypass the basic anatomy review. We know you understand what depolarization means and what the blood-brain barrier is.
Right, we're skipping the basic biology.
We're going straight into the hemodynamic consequences, the high-stakes pharmacology, and the priority nursing actions when the nervous system just starts to collapse.
I love it. Let's do it.
So let's start with the most explosive neurological emergency we see at the bedside. We're talking about the brain on fire, seizures, and specifically, the progression to status epilepticus.
So if we look at the baseline pathophysiology here, a seizure is an unchecked, synchronous, and excessive electrical discharge of neurons. But for us, the critical care focus isn't just the seizure itself.
Right.
It's the systemic fallout of that electrical storm.
Because normally the brain operates like a highly regulated, well-conducted orchestra, right?
Yeah.
A seizure is every single instrument suddenly playing at maximum volume, just completely uncoordinated.
That's a great way to picture it.
And while a standard seizure is bad, status epilepticus is when the concert hall catches on fire, the doors lock, and the fire suppression system completely fails.
That is the exact physiological reality. Status epilepticus, which is clinically defined as continuous seizure activity lasting longer than 5 minutes.
5 minutes, yeah.
Or recurrent seizures without a return to baseline consciousness in between. It is a profound emergency. But to understand how to stop it, we really have to look at what is happening at the synaptic cleft.
So we're basically talking about the battle between glutamate and GABA here.
Precisely. It starts with a trigger. So maybe it's a traumatic brain injury or, a severe sodium derangement.
Like severe hyponatremia.
Right. Or hypoglycemia, alcohol withdrawal. That trigger causes neuronal membranes to become wildly unstable, and you get a massive unregulated release of glutamate.
which is our primary excitatory neurotransmitter.
Exactly. Glutamate binds to the NMDA and AMPA receptors on the postsynaptic neurons, and that opens the calcium and sodium channels.
And that influx of positive ions is what causes that massive, sustained depolarization.
Yes. And normally, GABA-gamma aminobutyric acid steps in. GABA is the inhibitory neurotransmitter. It's the brakes.
Right.
It opens chloride channels, allowing negative ions in to hyperpolarize the cell and shut down the firing. But in status epilepticus, that GABAergic inhibition completely fails.
Or the receptors get internalized and just become insensitive, right?
Exactly. The glutamate cascade runs completely unchecked, and the abnormal firing jumps from those localized cortical circuits and just spreads through the entire cerebral cortex, deep into the thalamus and the brainstem.
And this is where that intensivist thinking has to kick in. Because the electrical discharge is the primary problem, sure, but the failing physiology is the energy demand.
Oh, absolutely.
I was looking at the cerebral metabolic rate of oxygen consumption during status epilepticus, and it is staggering. The brain is firing so fast that it demands more glucose and oxygen than the cardiopulmonary system can physically deliver.
Even if the patient were hemodynamically perfect.
Right. Even if everything else is working perfectly.
The metabolic demand spikes up to like 300% above baseline. Now, in the first few minutes, the body compensates. You'll see massive sympathetic surging.
Tachycardia, severe hypertension.
Hyperglycemia, yeah. Cerebral blood flow increases to try to meet the demand, but this compensation is incredibly short-lived.
Because the brain is essentially starving itself while sprinting a marathon.
Exactly. As the seizures continue past that 5-minute mark, the compensation shatters. The neurons deplete their ATP stores. And without ATP, the sodium-potassium pumps on the cell membranes just fail.
Which means water rushes into the cells, right?
Causing cytotoxic cerebral edema. And because the brain is starved of oxygen, the cells switch to anaerobic metabolism, which generates massive amounts of lactic acid.
Which leads right into the systemic decompensation. Because now the patient's airway reflexes fail, leading to ectal and postictal apnea.
Yep.
So now you have systemic hypoxemia, compounding the cerebral hypoxia. Plus, the continuous violent muscle contractions of a tonic-clonic seizure generate extreme heat.
Hyperthermia.
Yeah, and they break down muscle tissue, causing rhabdomyolysis and then subsequent renal failure. It's a cascade.
And if you do not chemically extinguish that electrical storm, the influx of intracellular calcium activates these destructive enzymes called caspases, which leads to apoptosis.
Wow.
The neurons literally digest themselves from the inside out. That is what causes irreversible anoxic brain injury or brain death.
Okay, so from a nursing assessment standpoint, we have to catch this early. We all know the classic presentation of a generalized tonic-clonic seizure, right? The sudden loss of consciousness, the extreme tonic muscle stiffening for maybe 10 to 20 seconds.
Followed by the clonic rhythmic jerking.
Right. And we're watching for the cyanosis, the trismus, the excessive salivation.
Yeah.
But the transition to status epilepticus is the real danger zone here.
You are watching the clock the second the seizure starts. If it crosses 5 minutes or, if they stop jerking but remain completely unresponsive, flaccid, and apneic without regaining a gag reflex before the next seizure starts.
You are in status.
You are in status.
What about the subclinical seizures? Because this feels like a massive ICU trap to me. You have a patient with severe ARDS. They're on a propofol infusion. Maybe they're chemically paralyzed with cisatracurium to facilitate the vent. Their body is perfectly still.
This is one of the most insidious ways we lose brain tissue in the ICU. Non-convulsive status epilepticus.
Because the brain is still seizing.
The brain is actively seizing, the glutamate is destroying the neurons, but because you've blocked the neuromuscular junction with a paralytic or heavily sedated the motor pathways, there is zero physical manifestation.
That's terrifying.
It is. If a patient has an unexplained failure to wake up after sedation holidays or unexplained hemodynamic instability with pupillary fluctuations, you must advocate for continuous EEG monitoring. The brain waves are the only way you'll see the fire.
Okay, let's talk diagnostics in the ADPIE framework. We're obviously pulling continuous EEG, getting a stat non-contrast CT to rule out a massive subarachnoid hemorrhage or a structural lesion.
Right.
And pulling a full metabolic panel to hunt for the trigger. Specifically looking for hyponatremia, hypomagnesemia, and hypocalcemia. But the assessment and diagnosis phase of ADPIE really requires us to prioritize.
The highest priority nursing diagnoses are always impaired respiratory function and risk for injury. The airway is paramount. So if we break down the priority nursing actions into a first, next, then sequence, the initial moments are critical.
Right, so first priority, ensure a patent airway, and protect them from injury. And I really want to hammer this home because old habits die hard in medicine. You lower them to the bed or the floor, you turn them on their side to drain the excessive secretions and prevent massive aspiration.
And you pad the rails.
Right, pad the rails. But you absolutely never, under any circumstances, place a tongue blade, a bite block, or your fingers into their mouth during the tonic or clonic phase.
It is a phenomenal way to lose a digit or completely shatter the patient's teeth. And then those teeth become airway foreign bodies. The masseter muscle spasm is just incredibly powerful.
Yeah, don't do it.
You also never physically restrain their limbs because you will cause joint dislocations and muscle tears. You just guide their movements to prevent them from striking hard objects.
So side lying, protect the head, clear the area. That's first. What's the next T priority?
Next T, you need IV access immediately if you don't have it, and you push rapid-acting rescue medications to break the electrical circuit.
Okay, then.
Then you administer the long-acting maintenance anti-seizure medications, prepare for endotracheal intubation if the apnea persists, and closely monitor hemodynamics because the drugs we push are going to drop their blood pressure.
Let's dive deep into that pharmacology because this is really where the intensivist mindset dictates the workflow. For acute rescue, our first-line agents are benzodiazepines, specifically phenyldiazepam.
Lorazepam is the drug of choice because it binds to the GABA receptor, acting as an allosteric modulator. It essentially increases the frequency of the chloride channel openings.
So it's boosting the brakes.
Yes. It rapidly enhances the brain's own inhibitory blanket to smother that glutamate fire. Now, if you do not have IV access, IM or intranasal midazolam is your backup because it absorbs incredibly fast through the mucosa.
But benzos only put the fire out temporarily, right?
Yeah.
They have a relatively short duration of action in the CNS. The embers are still hot, and the seizure will recur if we don't follow up immediately with a maintenance drug.
Exactly.
And this brings me to a major point of contention I see in the literature. We often follow lorazepam with IV phenytoin. I was reviewing the safety profile of phenytoin, and it is honestly terrifying.
It is a rough drug.
It causes severe gingival hyperplasia, bone marrow suppression, hepatotoxicity, and if it infiltrates outside the vein, it causes purple glove syndrome-like severe tissue necrosis that can require amputation. As an ICU nurse, my instinct is to aggressively question giving a drug this toxic. Why is this still a staple in our algorithms?
It's a very valid pushback, and it highlights the brutal calculus of neurocritical care. We use phenytoin because its mechanism of action prolonging the inactivation state of voltage-gated sodium channels is incredibly effective at preventing the spread of seizure activity.
So it keeps the fire from jumping.
Exactly. It has a long half-life, ensuring the electrical storm doesn't reignite once the lorazepam wears off. In the ICU, we're choosing the lesser of two evils. We can manage the gingival hyperplasia or the transaminitis next week. Right now, in this minute, we have to prevent anoxic brain death.
So we try to mitigate the risks. We prefer fosphenytoin, the prodrug, because it's water-soluble, it doesn't contain propylene glycol, and it is vastly safer on the peripheral veins.
Right, which drastically reduces the risk of purple glove syndrome.
But if we are forced to use IV phenytoin, you are monitoring that IV site with extreme vigilance.
Absolute vigilance. You also have to administer it slowly, no faster than 50 milligrams per minute, and only mix it in normal saline.
Because it precipitates in dextrose.
It will instantly precipitate and crystallize in dextrose solutions. You also must monitor their ECG continuously because rapid sodium channel blockade in the heart can cause severe bradycardia, heart blocks, and profound hypotension.
And we evaluate the effectiveness of this entire cascade by watching for a return to baseline Glasgow coma scale, sustained airway patency, and obviously the cessation of epileptiform discharges on the continuous EEG.
And we have to recognize the signs of deterioration. The patient is getting worse if they progress into refractory status epilepticus.
Meaning the lorazepam and the fosphenytoin just didn't work.
The seizures continue. At this point, the oxygen demand is insurmountable.
So escalation here means we are immediately calling the provider to the bedside, likely setting up for rapid sequence intubation to secure the airway, and initiating continuous infusions of propofol, midazolam, or pentobarbital. We are purposefully putting them into a medically induced coma to achieve burst suppression on the EEG.
Literally shutting the brain's electrical activity down to a flat line with occasional bursts just to force it to rest and reset.
In a crucial exam trap and clinical pearl for the ICU nurse here, when you are eventually weaning these patients off their drips or managing patients with known seizure disorders, you never, ever abruptly discontinue anti-seizure medications.
Never. Abrupt withdrawal removes that pharmacological inhibition, and the brain rebounds with a massive glutamate surge, throwing them right back into status epilepticus.
Okay, so if we synthesize this down to the core intensivist thinking, the problem is the uncontrolled neuronal depolarization. The failing physiology is the total depletion of cerebral ATP and systemic hypoxia.
Right.
The immediate threat is anoxic brain death and irreversible loss of the airway. The intervention is protecting that airway, pushing 5-lorazepam to halt the firing, and following with fosphenytoin to stabilize the membrane.
And our reassessment relies on continuous EEG and strict neurochecks. That is the exact mental model.
Okay, so let's hit the 5 things if we distill it to the absolute core rules.
Number 1, core patho. Uncontrolled neuron depolarization, depleting brain energy. Number 2, key assessment. Recognizing any continuous seizure crossing that 5-minute mark or no waking between them.
Number 3, the most dangerous complication. Status epilepticus leading to anoxia.
Number 4, priority nursing action. Protect the airway, position on the side, do not insert mouth objects.
And number 5, most important treatment, IV lorazepam, followed by fosphenytoin.
So if you see a patient with prolonged rhythmic jerking without recovery, or a sedated patient with unexplained tachycardia and pupillary changes, you think status epilepticus.
And you do secure the airway and push the IV benzos. All right, let's pivot. We've been talking about the brain acting like an overloaded power grid, sparking completely out of control. But there's an entirely different type of neurological emergency in the ICU. What happens when the brain's power plant is generating electricity perfectly, the signal travels down the spinal cord, hits the peripheral nerve, but the wires are severed right before they reach the lights.
Muscle never gets the message.
Exactly. That is the terrifying reality of myasthenia gravis.
This is a phenomenal contrast. Myasthenia gravis, or MG, is a chronic autoimmune disease targeting the neuromuscular junction. It is characterized by fluctuating weakness of skeletal muscles that reliably worsens with repetitive activity and improves with rest.
From an epidemiological standpoint, it typically affects young women in their 20s and 30s and older men in their 50s and 60s. But the reason the intensivist cares about MG isn't because the patient has weak arms or legs.
No, we care because the bulbar muscles, the muscles controlling swallowing, speaking, and chewing, and the diaphragm, those are skeletal muscles. When the neuromuscular junction fails there, you lose the airway and you lose ventilation. That is a myasthenic crisis.
Let's trace the pathophysiology from the origin. The exact trigger is often linked to thymic hyperplasia, or thymomas, which are tumors of the thymus gland, which basically disrupt immune tolerance.
Yes, and the physiological change is that B cells produce IgG autoantibodies that cross the bloodstream and physically attach to the nicotinic acetylcholine receptors, the AChRs, on the motor end plate of the muscle.
And acetylcholine is the neurotransmitter that normally bridges the gap, right? The nerve releases AC, it crosses the synaptic cleft, binds to the receptor on the muscle, triggers sodium influx, and the muscle contracts.
But in MG, the autoantibodies do 3 destructive things. First, they competitively block the ACA from binding.
They just get in the way.
Right. Second, they cross-link the receptors, causing the muscle cell to internalize and degrade them. And third, they activate the complement cascade, which literally blasts holes in the postsynaptic membrane, flattening the intricate folds of the motor end plate.
Which drastically reduces the surface area and the total number of available receptors. So why does the weakness fluctuate? Why are these patients relatively strong when they wake up in the morning, but completely exhausted by the evening?
It comes down to a harsh numbers game at the synapse. After a period of rest, the few healthy receptors they have left are completely unbound and ready. The presynaptic nerve has a full store of acetylcholine.
Gus.
When they wake up and start moving, the initial nerve impulses release massive amounts of ACE, which successfully finds the sparse receptors. But with repetitive activity talking for a long period, chewing a tough meal, simply blinking,
Yeah.
the nerve starts releasing slightly less ACE with each subsequent firing, which is actually normal. But because the MG patient has an artificially low number of receptors, this normal depletion drops the SCO levels below the threshold needed to trigger a muscle contraction.
So the few available receptors are just overwhelmed.
Exactly, and the muscle simply stops responding.
And the assessment findings track this exact progression. Early on, it almost always presents in the ocular muscles because they have smaller motor units and a very high firing frequency, so they deplete their AC rapidly. You see ptosis, the drooping eyelids, and diplopia, double vision.
The classic clinical assessment is the peak sign. You ask the patient to close their eyes as tightly as they can and hold it. Within 30 seconds, the orbicularis oculi muscle fatigues and the eyes slowly peek open. They literally cannot keep their eyelashes buried.
Wow. And as the disease progresses throughout the day, their voice will fade to a whisper or become severely nasal during a conversation. They will complain of jaw fatigue halfway through eating a meal.
Which leads directly into the late, highly dangerous findings. When the bulbar muscles fatigue, they lose the ability to manage their own secretions. They start drooling. They lose the gag reflex, and then the intercostal muscles and the diaphragm begin to fail. This is the crisis.
When we look at diagnostics, the chronic management involves drawing serum AChR antibodies, or muscle-specific kinase, the MuSK antibodies. We use electromyography, specifically single-fiber EMG, to definitively prove that the muscle action potential drops off with repetitive nerve stimulation.
But in the ICU, our diagnostic focus shifts to respiratory mechanics. We are closely monitoring serial forced vital capacities, or FVC, and negative inspiratory force, the NIF. When those numbers plummet, respiratory failure is imminent.
Let's apply ADPIE. The assessment requires extreme vigilance for bulbar weakness. Is there speech slurring? Are they coughing when they swallow water? The diagnosis is impaired spontaneous ventilation and high risk for aspiration.
And the planning is entirely centered on preventing aspiration and maintaining alveolar ventilation.
Which brings us to a massive critical implementation step for the bedside nurse. You must administer their oral maintenance medications exactly on time, specifically scheduling them 30 to 45 minutes before meals.
Because they need that drug to reach its absolute peak effect precisely when they are chewing and swallowing. Otherwise, they will aspirate their food directly into their lungs.
This isn't a drug you can give an hour late because you were busy in another room. The timing is life and death.
And if we look at the priority nursing actions when they start to deteriorate, first, you assess their respiratory effort, their ability to clear secretions, and their vital capacity. Next, you prepare for non-invasive positive pressure ventilation, like BiPAP, or anticipate immediate rapid sequence intubation if their ABG shows rising PARCO2, indicating profound hypoventilation.
Right.
Then you must do the most difficult thing in critical care neurology. You have to figure out exactly what kind of crisis they're in.
And this is the crux of myasthenia gravis in the ICU, because there are two different crises, and the primary symptom for both of them is exactly the same: severe, life-threatening muscle weakness and respiratory failure.
It's all about the pharmacology of the anticholinesterase drugs, specifically pyridostigmine.
Let's break down the mechanism of action. Acetylcholinesterase is the enzyme that lives in the synaptic cleft. Its job is to act like a vacuum cleaner, instantly breaking down acetylcholine after a nerve fires so the muscle can relax and reset.
Exactly. In MG, we want to break that vacuum cleaner. Pyridostigmine is a reversible acetylcholinesterase inhibitor. It stops the enzyme from working, which leaves whatever acetylcholine the nerve releases floating around in the synapse for a much longer time,
drastically increasing the odds that it will bump into one of the few surviving receptors and trigger a contraction.
Right.
Okay, so logically, if the patient just needs more acetylcholine to overcome the autoantibody blockade, why don't we just flood their system with massive doses of pyridostigmine? If they get weak, just give them more drug, right?
That specific line of thought is exactly what kills MG patients in a cholinergic crisis. It is a terrifyingly delicate biochemical balance. If the patient is underdosed or if they experience a massive physiological stressor like a severe respiratory infection, surgery, or pregnancy, the requirement for asatir shoots up, but they don't have enough pyridostigmine on board.
The muscles fail from a lack of stimulation.
Yes. This is a myasthenic crisis. The treatment is giving more anticholinesterase drugs or removing the autoantibodies.
But if they are overdosed,
if a patient takes too much pyridostigmine, the acetylcholinesterase enzyme is completely shut down. The synaptic cleft is absolutely flooded with acetylcholine. It binds to the receptors, the muscle contracts, but because the ACU isn't cleared away, it stays bound.
It just sits there.
The motor end plate remains in a state of continuous, sustained depolarization.
It's essentially depolarizing neuromuscular blockade, exactly like acetylcholine.
Precisely. The muscle becomes refractory to any further signals. It locks up, becomes exhausted, and goes into complete flaccid paralysis. This is a cholinergic crisis.
So you have a patient who is completely paralyzed, unable to breathe. How do you distinguish if they are paralyzed because they don't have enough drug myasthenic, or paralyzed because they have too much drug cholinergic? This is pattern recognition at its finest.
You look at the autonomic nervous system. Acetylcholine doesn't just work on skeletal muscle at the nicotinic receptors, it is also the primary neurotransmitter for the entire parasympathetic nervous system at the muscarinic receptors.
Right.
A myasthenic crisis is pure skeletal muscle weakness. But a cholinergic crisis means the entire parasympathetic system is massively overstimulated.
We use the acronym SLUDGE to remember the muscarinic effects.
Yep.
Salivation, lacrimation, urination, defecation, GI cramping, and emesis.
Exactly. If the patient is paralyzed and in respiratory failure, but they are also profusely sweating, drowning in excessive saliva, having explosive diarrhea, experiencing severe bradycardia, and their pupils are pinpoint meiosis, they are in a cholinergic crisis. They are overloaded with drug.
And historically, we use the edrophonium or tensilon test to differentiate the two when the clinical picture was muddy. Edrophonium is an ultra-short-acting IV anticholinesterase. It blocks the enzyme for just a few minutes.
You inject the edrophonium. If the patient suddenly gets significantly stronger, can open their eyes, and can take a deep breath, it proves they needed more acetylcholine in the synapse. They were in a myasthenic crisis.
But if they're already in a cholinergic crisis and you inject edrophonium, you just threw a bucket of gasoline on an already raging fire.
Yes. You completely overwhelm whatever tiny fraction of the enzyme was still working. The patient will immediately become profoundly weaker. They may go into complete respiratory arrest, and the muscarinic effects will trigger massive vagal stimulation leading to severe bradycardia or asystole.
Which brings us to the ultimate exam trap and critical safety pearl. You must never, ever allow an edrophonium test to be performed without having atropine drawn up in a syringe, sitting physically at the bedside.
Atropine is a potent muscarinic antagonist. It blocks the acetylcholine from binding to the parasympathetic receptors, reversing the severe bradycardia, the bronchospasm, and the excessive secretions caused by the edrophonium.
It won't reverse the skeletal muscle paralysis. They will still need the ventilator, but it will stop their heart from stopping.
Exactly.
Let's talk about the big gun interventions for a myasthenic crisis in the ICU. When the pyridostigmine isn't enough, we escalate to IV corticosteroids and immunosuppressants to halt the B cells, but the rapid life-saving procedures are plasmapheresis and IVI.
Plasmapheresis, or therapeutic plasma exchange, is essentially dialysis for antibodies. We pull the patient's blood, centrifuge it to separate the plasma, discard the plasma containing the rogue AChR autoantibodies, and return the red blood cells mixed with a replacement fluid like albumin.
It physically clears the weapon from the bloodstream, providing rapid, albeit temporary, improvement in muscle strength.
IV'd, intravenous immunoglobulin, involves infusing a massive dose of pooled IgG antibodies from thousands of donors. The exact mechanism is incredibly complex, but essentially it overwhelms the patient's immune system, downregulates autoantibody production, and neutralizes the attacking antibodies.
But both therapies take days to reach peak effect. In the interim, the hemodynamics and respiratory management are paramount. The issue here is purely ventilation, not oxygenation. Their lung parenchyma is perfectly healthy.
The pump is just broken. As their diaphragm tires, their tidal volume drops, their PaO2 rises, and they develop a profound respiratory acidosis. You are intervening with mechanical ventilation to do the work of breathing for them until the plasmapheresis kicks in.
So we recognize deterioration if their voice changes to a whisper, if they start drooling because they can't manage their saliva, or if they develop a rapid, shallow breathing pattern with a falling vital capacity.
And escalation means you do not wait for them to desaturate or turn cyanotic. By the time an NG patient's oxygen saturation drops, they are already in extremis. You call a rapid response or alert the intensivist the moment their bulbar symptoms worsen.
Bringing it back to the intensivist thinking model, the problem is bulbar and diaphragmatic weakness. The failing physiology is the autoimmune destruction of neuromuscular transmission, leading to failure of the respiratory pump.
The immediate threat is hypoventilation and massive aspiration.
The intervention is securing the airway, utilizing BiPAP or endotracheal intubation, and initiating plasmapheresis or IVIG.
And the reassessment is serial vital capacities, knife scores, and continuous ABG analysis.
Let's lock down the 5 things here. Number 1, core patho, autoimmune destruction of HE receptors.
Number 2, key assessment, weakness that worsens with activity. Look for the ptosis dysphagia.
Number 3, most dangerous complication, respiratory failure crisis.
Number 4, priority nursing action. Protect the airway and differentiate the crisis type.
And number 5, most important treatment: pyridostigmine for maintenance or plasmapheresis for crisis.
So if you see a patient with profound acute weakness accompanied by pinpoint pupils, severe salivation, and diarrhea, you think cholinergic crisis.
And you do immediately hold the pyridostigmine. Prepare to push atropine for the bradycardia and prepare to intubate.
Exactly. You have to recognize the autonomic overload.
This perfectly segues into our next category. We've covered the acute electrical fire and the severed neuromuscular connection. Now we're diving into section 3, the degenerative crashes. We are looking at multiple sclerosis, Parkinson's disease, amyotrophic lateral sclerosis, and Huntington's disease.
These represent a unique challenge in critical care.
And I think it's important to ask the obvious question here. These are classic, slow-moving, chronic outpatient diseases. Most of these patients manage their symptoms at home for years, sometimes decades. Why does an elite ICU nurse managing vasoactive drips and CRT machines need to memorize the intricacies of Parkinson's or MS?
Because they do not die of the underlying disease in the outpatient clinic. They die of the complications of the disease: severe aspiration pneumonia, profound immobility, and inevitable respiratory failure. And they die of those complications right in front of us in the intensive care unit.
Right.
When a patient with advanced MS or Parkinson's gets admitted for a seemingly simple UTI or mild sepsis, their chronic neurologic baseline is completely shattered. The physiological stress of the infection exacerbates every single neurologic deficit they have. What was mild dysphagia at home becomes a catastrophic aspiration event in the hospital.
Let's break these down one by one, hitting the 80-20 for each, starting with multiple sclerosis. MS is an autoimmune demyelinating disease of the central nervous system. Demographically, we are looking primarily at women between 20 and 40, and the relapsing remitting phenotype is by far the most common.
To grasp MS, you have to understand myelin. Myelin is the lipid-rich sheath produced by oligodendrocytes in the CNS. It wraps around the axons, acting as heavy insulation. This insulation allows electrical action potentials to jump rapidly down the axon via saltatory conduction.
But in MS, the pathophysiology goes violently wrong. The prevailing theory is an environmental trigger, likely a viral infection like Epstein-Barr, in a genetically susceptible individual. This triggers a massive autoimmune response. T lymphocytes become autoreactive.
Right.
They cross the blood-brain barrier, which they are not supposed to do, and they misidentify the myelin sheath as a foreign invader. They release cytokines, recruiting macrophages, which physically attack and strip the myelin off the axons.
It is exactly like stripping the thick rubber insulation off a live electrical wire. The immediate consequence is severe local inflammation. Because the axon is exposed, the electrical impulses drastically slow down, short-circuit, or are blocked entirely. This causes the acute clinical symptoms: profound weakness, numbness, or loss of vision.
The compensation is that the inflammation eventually subsides. The oligodendrocytes attempt to remyelinate the nerve, and the patient may regain function, which is the remitting phase. But the decompensation is cumulative. Over time, the oligodendrocytes are destroyed and lose the ability to repair the damage.
The underlying axon itself is severed. And to heal the tissue defect, astrocytes proliferate and form dense, rigid, scar tissue glial scars, or plaques. This process is called gliosis. Once the plaque forms, the neurologic function of that pathway is permanently, irreversibly lost.
And because these plaques form randomly in time and space throughout the brain and spinal cord, the assessment findings are incredibly highly variable. It's often described as spotty. You might see optic neuritis causing unilateral blindness.
A classic diagnostic assessment is Laramie sign. When the patient flexes their neck forward, it stretches the demyelinated cervical spinal cord, sending a sudden, intense electric shock sensation radiating down the spine and into the limbs.
You will also see profound, debilitating fatigue, cerebellar ataxia, and severe bowel and bladder dysfunction. They often develop a spastic or flaccid neurogenic bladder, which leads to urinary retention, chronic catheterization, and ultimately recurrent severe UTIs, which frequently land them in the ICU with urosepsis.
The priority nursing actions in the hospital revolve around preventing triggers. Heat, severe stress, and systemic infection drastically impair nerve conduction in already damaged axons. A phenomenon known as Ohoff's sign occurs where even a slight elevation in core body temperature, like a mild fever from a UTI or simply a hot shower, causes a sudden, drastic worsening of all their MS symptoms. You must aggressively treat fevers and maintain a cool environment.
For medications, when they are in an acute relapse, we hit them with high-dose IV corticosteroids like methylprednisolone to rapidly shut down the acute inflammation and seal the blood-brain barrier. But it's their outpatient disease-modifying therapies that hold the major ICU trap.
Yes. These patients are often on potent immunomodulators and immunosuppressants to slow the disease progression. Drugs like natalizumab or fingolimod work by essentially trapping the autoreactive lymphocytes in the lymph nodes, preventing them from crossing into the brain.
But the trap is that by entirely stripping the brain of its immune surveillance, you leave it completely defenseless against opportunistic infections, specifically the JC virus.
Exactly. The JC virus is a common virus that sits dormant in the kidneys of most of the population. But in these deeply immunosuppressed MS patients, it can migrate to the brain, infect the oligodendrocytes, and cause progressive multifocal leukoencephalopathy, or PML. It is a catastrophic, rapidly fatal viral demyelinating disease of the brain.
If your MS patient on these drugs comes into the ICU with sudden severe new cognitive decline, personality changes, or hemiparesis that doesn't fit their typical MS relapse pattern, you must suspect PML.
Let's move to Parkinson's disease. PD is a progressive, relentless neurodegenerative disorder of the extrapyramidal motor system, typically affecting men over the age of 70.
The pathophysiology of Parkinson's is localized to the basal ganglia, specifically a tiny structure in the midbrain called the substantia nigra. The neurons here are responsible for synthesizing and releasing dopamine. Dopamine is an inhibitory neurotransmitter in the motor circuitry. It acts as the braking system, smoothing out and refining our purposeful movements.
But in PD, for reasons we still don't fully understand, likely a mix of genetics and environmental toxins, these specific dopamine-producing neurons undergo progressive apoptosis. They die off, and they are not replaced.
And the decompensation arises because motor control requires a perfect equilibrium between dopamine, which inhibits movement, and acetylcholine, which excites movement. As the dopamine levels plummet by 60, 70, 80%, that equilibrium is shattered. Acetylcholine goes completely unopposed.
The brain's motor cortex is basically mashing the gas pedal, the HA, while the brakes, the dopamine, have completely failed. This unopposed excitatory signaling causes the classic assessment findings, which we group into the TRAP acronym.
Tremorate. Tremor, specifically a resting tremor, classically presenting as a rhythmic pill-rolling motion of the thumb and forefinger when the hand is at rest. Rigidity, particularly cogwheel rigidity, where if you passively flex their arm, it moves with jerky, clicking catches due to the simultaneous contraction of opposing muscle groups.
Akinesia, or bradykinesia, is the profound slowness of movement. This is what causes the classic Parkinsonian presentation. The mask-like, deadpan, expressionless face, the short shuffling gait, and the severe difficulty initiating movement.
It also affects the bulbar muscles, right? So they swallow infrequently, leading to constant drooling and high risk of aspiration.
And finally, postural instability. Their center of gravity shifts forward and they lose their righting reflexes. If you perform the pull test standing behind them and pulling slightly backward on their shoulders, they will not catch their balance. They will simply fall straight backward like a felled tree.
Which brings us to the absolute most critical ICU pearl for Parkinson's disease. It revolves around their primary medication, levodopa combined with carbidopa, widely known as Sinemet.
Let's look at the kinetics here. You can't just give a patient a pill of pure dopamine because dopamine is a massive molecule that cannot cross the blood-brain barrier. So we give levodopa, which is a metabolic precursor that can cross the barrier, enter the brain, and be converted into active dopamine by the surviving neurons.
But levodopa has a major flaw. If given alone, enzymes in the peripheral bloodstream will break it down almost instantly, causing severe systemic side effects like profound nausea and cardiac dysrhythmias, and very little of it will actually reach the brain. That is why it is always combined with carbidopa. Carbidopa acts as a bodyguard. It inhibits the peripheral enzymes, protecting the levodopa in the bloodstream, allowing massive amounts of it to reach the blood-brain barrier intact.
So why is this combination so terrifyingly critical in the ICU?
Because the half-life of levodopa is incredibly short, and these patients have no natural dopamine reserves left. If a Parkinson's patient in the ICU misses a scheduled dose of Sinemet by even 30 to 45 minutes, maybe because they were down in CT scan, or the pharmacy was slow tubing it up, their dopamine levels will crash to zero.
And the physiological consequence of that crash is sudden, profound, total body rigidity.
Exactly. They become locked in. They lose the ability to expand their chest wall to breathe. Most dangerously, they completely lose the ability to swallow. They will aspirate their own saliva, or if they vomit, they will aspirate the emesis directly into their lungs. Fatal aspiration pneumonia is the leading cause of death in Parkinson's. Strict, down-to-the-minute adherence to their home medication schedule is your absolute #1 priority nursing action. You cannot delay these drugs.
What happens if they experience an off episode? We see this in advanced PD where the Cinemet suddenly stops working unpredictably and they freeze up entirely.
For acute off episodes, we use apomorphine. Despite the name, it has no narcotic properties. It is a highly potent, rapid-acting dopamine receptor agonist given as a subcutaneous injection. It essentially forces the dopamine receptors open to break the rigidity.
But there is a massive exam and clinical trap here. Apomorphine triggers the chemoreceptor trigger zone in the medulla, causing violent, intractable nausea and vomiting. You have to give an antiemetic with it, but you must never, under any circumstances, give it with a 5-HT3 receptor antagonist like ondansetron Zofran.
This is a lethal interaction. If you combine apomorphine with Zofran, the combination of massive dopamine agonism and serotonin antagonism triggers a profound vagal reflex and catastrophic systemic vasodilation. The patient will experience fatal hypotension and immediate loss of consciousness. It is strictly contraindicated. You must use a different class of antiemetic, like trimethylbenzamide.
Okay, let's look at amyotrophic lateral sclerosis, ALS, or Lou Gehrig's disease. This is arguably the most devastating diagnosis in neurology. It is a progressive, fatal neurodegenerative disease that destroys the motor neurons in the brainstem and the spinal cord. It is rapidly progressive. Death usually occurs within 3 to 5 years of diagnosis. The exact pathophysiology is still debated, but a massive component is excitotoxicity. For various genetic and metabolic reasons, there is an excessive accumulation of glutamate in the synaptic clefts of the motor pathways. This massive overstimulation causes calcium influx, oxidative stress, and the ultimate destruction of both upper and lower motor neurons.
The physiological change is blunt. The brain's electrical signal simply cannot reach the skeletal muscles.
And the decompensation is rapid. Without nerve stimulation, the muscles undergo severe denervation atrophy. Because it affects both upper and lower motor neurons, the assessment findings are a brutal mix. You will see lower motor neuron signs like severe flaccid weakness, muscle wasting, and fasciculations, those visible rippling twitches under the skin, and you will see upper motor neuron signs like spasticity and hyperreflexia.
The weakness inevitably spreads from the distal extremities inward to the core, but the most horrifying aspect of ALS is what it spares. The sensory pathways, the autonomic nervous system, and most devastatingly, the frontal cortex remain completely intact. Their cognition is perfectly preserved. They are entirely aware of their surroundings, their intellect is sharp, but they become completely, literally trapped inside a paralyzed, failing body.
When an ALS patient arrives in the ICU, it is almost entirely for respiratory failure or massive aspiration. As the bulbar neurons die, they lose the ability to swallow. As the cervical and thoracic neurons die, the diaphragm and intercostal muscles paralyze.
Our ICU focus is airway and ethics. We are monitoring their forced vital capacity. We use Riluzole, a medication that blocks tetrodotoxin-sensitive sodium channels, which decreases glutamate release. It isn't a cure, it only slows the progression and delays the need for a tracheostomy by a few months. But the priority nursing action here is profoundly human. Because their cognition is intact, you must facilitate communication using eye-tracking devices or letterboards, and you must engage the intensivist, the patient, and the family in proactive, explicit discussions about end-of-life wishes and mechanical ventilation long before they lose the physical ability to make their choice known.
Finally, in the degenerative category, we have Huntington's disease. HD is a rare autosomal dominant genetic disorder. If one parent has the mutated HTT gene, every child has a 50% chance of inheriting it. It usually strikes right in the prime of life, between 30 and 55.
The genetics are fascinating. It's caused by an expansion of CAG trinucleotide repeats on chromosome 4. The mutated Huntington protein misfolds, aggregates, and becomes profoundly toxic to the neurons in the striatum of the basal ganglia.
If we compare the pathophysiology to Parkinson's, it's almost the exact mirror opposite. In Parkinson's, you have no dopamine, leaving acetylcholine unopposed, causing rigidity. In Huntington's, the toxicity destroys the neurons that produce GABA and acetylcholine.
Exactly. You lose the inhibitory GABA pathways, leaving a massive, unopposed excess of dopamine signaling.
So instead of being frozen and slow, the Huntington's patient has excessive, explosive, involuntary movements.
We call this chorea. It presents as constant riding, twisting, dance-like movements of the face, limbs, and trunk. But the mutated protein also destroys the cortical neurons, leading to severe psychiatric decline, profound depression, impulsivity, psychosis, and inevitable progressive dementia.
The ICU focus for HD revolves around two immense challenges: severe caloric deficit and airway protection. Because the patient is constant moving, writhing, and muscle spasming 24 hours a day, their hypermetabolic state is staggering. They can burn 4,000 to 5,000 calories a day just lying in bed.
And because the chorea heavily involves the facial and pharyngeal muscles, their swallowing is totally uncoordinated. If you try to feed them those 5,000 calories by mouth, they will aspirate and die of pneumonia. The priority nursing action is managing deep enteral feeding tubes to ensure massive caloric delivery while strictly preventing aspiration. We also utilize medications like tetrabenazine, a vesicular monoamine transporter 2, or VMAT2 inhibitor. It essentially depletes the dopamine stores in the nerve terminals, which help suppress the severe chorea so they can rest.
Let's pull these 4 degenerative crashes into the intensivist thinking framework.
Across the board, the problem is a progressive underlying neurologic decline. The failing physiology is the eventual failure of the bulbar swallowing mechanisms and diaphragmatic paralysis. The immediate threat in the ICU is always massive aspiration pneumonia, severe malnutrition, or terminal hypoventilation.
The intervention requires meticulous, strict adherence to home medication schedules, especially levodopa, early use of non-invasive ventilation, and aggressive airway protection strategies. The reassessment is continuous, serial monitoring of their respiratory mechanics and their ability to handle their own secretions.
Synthesizing the 5 core rules for the degenerative states. Number 1, core patho. Progressive loss of myelin in MS, dopamine in PD, motor neurons in ALS, or Achi-GABA in HD.
Number 2, key assessment. Identifying any worsening dysphagia, change in vocal quality, or increasing respiratory effort.
Number 3, most dangerous complication. Universally aspiration pneumonia leading to hypoxemic respiratory failure.
Number 4, priority nursing action. Down to the minute adherence to the Parkinson's medication schedules.
And number 5, most important treatments. Supportive care, airway protection, and early, clear communication regarding end-of-life directives before a crisis hits.
So if you have a Parkinson's patient admitted for a minor infection who suddenly becomes rigid, unable to speak, and begins choking on their saliva, you immediately recognize that they missed their Sinemet dose. You must escalate to the provider instantly to get that drug administered before they completely lose the airway.
That brings us to our final exploration. We're looking at the neuro exam and identifying the red flags hidden in common complaints. We are talking about headaches and restless leg syndrome.
This is an exercise in filtering the noise to find the lethal signal.
And I want to push back on this topic as well. If I am an elite ICU nurse, balancing multiple vasoactive drips, managing a CRRT circuit, and tweaking a complex ventilator mode, why am I spending my time studying tension headaches? That feels like outpatient urgent care medicine, not critical care.
I hear that constantly, but you have to know precisely what a normal benign symptom looks like so you can instantly spot the abnormal, lethal one. The ICU is chaotic. Patients complain of pain constantly, but primary headaches, your standard tension headaches, migraines, or cluster headaches, are not going to kill the patient. Secondary headaches will kill them in minutes.
Let's define that. A secondary headache is a symptom of a catastrophic underlying pathology. We're talking about a ruptured cerebral aneurysm causing a subarachnoid hemorrhage, a rapidly expanding brain tumor, or bacterial meningitis.
Exactly. So what are the red flags? When does a headache mandate an immediate halt to everything else you are doing?
We are looking for the thunderclap headache. The patient describes it as a sudden, explosive onset, literally the worst headache of their entire life, reaching maximum intensity in seconds. And it is accompanied by systemic neurologic deficits, severe confusion, sudden unilateral weakness, pupillary changes, or intractable vomiting. But the most specific red flag is nuchal rigidity, a profoundly stiff neck.
Why the stiff neck? Because blood from a ruptured aneurysm in the subarachnoid space, or thick, purulent pus for meningitis, is highly irritating to the meninges, the membranes wrapping the brain and spinal cord. When those inflamed meninges are stretched, even slightly, by flexing the neck forward, the body triggers a massive reflex muscle spasm in the cervical spine to splint the neck and prevent further stretching. If you see a thunderclap headache with a stiff neck, the failing physiology is rapidly rising intracranial pressure or massive arterial bleeding. The threat is brain herniation. You immediately call for a STAT non-contrast CT scan and a neurosurgical consult.
But if we rule out the bleeds, we have to manage the primary headaches, because the pain itself causes sympathetic surging that destabilizes our ICU patients. Tension headaches are bilateral, squeezing, band-like pain. We treat them with simple NSAIDs. But cluster headaches are entirely different. They're classified as trigeminal autonomic cephalagias.
Cluster headaches are fascinating, and the pain is excruciating, often described as worse than childbirth or passing a kidney stone. They primarily affect men. The exact pathophysiology involves a dysfunction in the hypothalamus and the trigeminal vascular complex, specifically cranial nerve 5.
The assessment is highly specific. A patient will wake up abruptly in the middle of the night with severe, bone-crushing, sharp, stabbing pain localized exactly in and around one eye. It is strictly unilateral.
And you will see the autonomic symptoms on that exact same side of the face. They will have severe lacrimation, their eyes pouring tears, ptosis, conjunctival injection, nasal congestion, and meiosis. The pain is so severe they are extremely restless, pacing the room, rocking back and forth. These attacks happen in clusters multiple times a day for weeks or months, and then they vanish entirely for a year.
The 80-20 critical care treatment pearl for cluster headaches is brilliant in its simplicity. You don't need massive doses of IV narcotics. You use high-flow 100% oxygen. You put a non-rebreather mask on the patient, crank the flow to 12 to 15 liters per minute, and have them breathe it for 15 to 20 minutes.
The physiological mechanism is beautiful. 100% oxygen is a potent cerebral vasoconstrictor. By forcing hyperoxia, you rapidly constrict the dilated blood vessels feeding the trigeminal nerve, drastically reducing the localized blood flow and the neurogenic inflammation, which aborts the headache almost immediately.
That is incredible. Now contrast that with migraines.
Migraines are driven by neuronal hyperexcitability in the cerebral cortex. A trigger causes a wave of depolarization called cortical spreading depression, which activates the trigeminal nerve, causing massive release of neuropeptides like calcitonin, gene-related peptide, CGRP. This causes profound vasodilation and inflammation of the meningeal blood vessels.
The assessment is the classic unilateral throbbing, pulsating pain that is synchronous with their heartbeat. It's often preceded by an aura visual disturbances like flashing lights, zigzag lines, or sensory tingling. They will have severe photophobia and phonophobia. Unlike the pacing cluster headache patient, the migraine patient wants to lie perfectly still in a dark, silent room.
For severe acute migraines in the hospital, we use triptans, like sumatriptan. These drugs are serotonin 5-HT1B and 1D receptor agonists. They bind to the receptors on the cranial blood vessels and force them to vasoconstrict, shutting down the inflammation.
But here is the massive exam and clinical trap with triptans.
Because triptans cause systemic vasoconstriction, they don't just constrict the blood vessels in the head, they constrict the coronary arteries. You must never give a triptan to a patient with a history of ischemic heart disease, a previous myocardial infarction, angina, or severely uncontrolled hypertension. If you give sumatriptan to a patient with bad coronaries, you will induce severe coronary vasospasm and cause a massive ST elevation myocardial infarction right there in the ICU bed.
Let's finish our deep dive with restless leg syndrome, RLS, or Willis-Ekbom disease. Again, challenging the premise, why does an intensivist care about a leg twitch?
Because ICU delirium is the enemy of survival. Delirium is fueled, exacerbated, and sustained by a profound lack of sleep. RLS causes an overwhelming, irresistible, and extremely uncomfortable urge to move the legs. Patients describe it as a creeping, crawling, or burning sensation deep inside the muscle. And crucially, it follows a circadian rhythm. It gets drastically worse at night when they are lying, still trying to rest.
If they can't sleep, their brain cannot clear metabolic waste. They become deeply encephalopathic. They rip out their central lines, they self-extubate, they require massive doses of sedatives, and their mortality risk skyrockets. The leg twitch is the domino that knocks over their entire ICU recovery.
The pathophysiology points to a dysfunction in the brain's basal ganglia circuits that utilize dopamine, combined with abnormal iron metabolism in the CNS. Dopamine levels naturally dip in the evening, which removes the inhibitory control over the spinal reflexes, triggering the spasms.
How do we intervene?
First, you act like an intensivist and hunt for the secondary reversible causes. You check a full iron panel and ferritin levels. Iron is a necessary cofactor for the enzyme that synthesizes dopamine. If the ferritin is low, you replete the iron. You also check their renal function, as uremia exacerbates RLS.
And pharmacologically, we treat it by replacing the inhibition. We use dopamine agonists like ropinirole or pramipexole, or we use alpha-2 delta calcium channel ligands like gabapentin or pregabalin to quiet the overactive nerve signaling. You treat the legs, you let the patient achieve REM sleep, and you might just cure their ICU delirium without ever touching an antipsychotic.
Applying the intensivist thinking for headaches, the problem is severe head pain. The failing physiology is potentially rapidly rising ICP, hemorrhage, or profound trigeminal vasodilation. The immediate threat is uncal herniation from an undiagnosed secondary bleed. The intervention is rapid assessment for red flags, mutual rigidity, AMS, and targeted therapies like 100% oxygen for clusters. Reassessment mandates strict, highly frequent neurochecks to catch subtle deterioration.
Let's lock in the 5 core rules for the neuroexam flags. Number 1, core patho, vasodilation inflammation for migraine, or trigeminal autonomic for cluster.
Number 2, key assessment. Differentiating the unilateral throbbing of a migraine from the unilateral eye pain, tearing, and pacing of a cluster headache.
Number 3, most dangerous complication. Dismissing a headache as a nuisance and missing a lethal subarachnoid hemorrhage.
Number 4, priority nursing action. Instantly assessing any new severe headache for a stiff neck, projectile vomiting, or altered mental status.
And number 5, critical treatments. 100% oxygen for cluster and triptans for migraines, but only after definitively clearing their cardiac history.
So if you see a patient clutching their head, screaming that it's the worst pain of their life, and they cannot touch their chin to their chest without agonizing pain and confusion, you think subarachnoid hemorrhage. You immediately call for a provider and transport them for a STAT CT scan.
Let's pull this entire landscape together. We started at the absolute extreme, the explosive, chaotic fire of status epilepticus, where the brain rapidly burns through its own energy reserves, necessitating immediate chemical suppression with benzodiazepines to prevent cellular starvation. We move to the silent, suffocating threat of myasthenia gravis, where the synapses simply fail to connect, the diaphragm stops, and you must perfectly thread the needle between a myasthenic and a cholinergic crisis using acetylcholinesterase inhibitors.
We watch the slow, inevitable fade of the degenerative diseases, MS, Parkinson's, ALS, Huntington's, and realize that in the highly pressurized environment of the ICU, missing a single dose of levodopa can induce fatal rigidity and aspiration in minutes.
And finally, we learn to filter through the noise of common complaints to find the lethal red flags of a ruptured aneurysm and how to utilize a simple oxygen mask to abort a cluster headache.
It is an immense amount of complex pathophysiology, but when you apply that 80-20 rule, when you strip away the outpatient management and focus purely on what will kill the patient in the next hour, the patterns become crystal clear.
To you, the listener, the strong ICU nurse stepping up to that next level of practice. Being a top-tier critical care thinker isn't just about memorizing the black box warnings of the medications. It is about deeply connecting the invisible, microscopic cellular failures. The depleted dopamine in the substantia nigra, the destroyed acetylcholine receptors at the motor end plate, the unchecked glutamate depolarization, to the crashing blue apneic patient lying in the bed right in front of you.
If you understand the why of the pathophysiology, the what to do of the nursing action doesn't require rote memorization. It becomes entirely instinctive. You know why you hold the Zofran. You know why you don't use the tongue blade. You know why the Cinemed is critical.
So to circle back to our opening idea, the neuro-ICU is not a clean binary broken bone. The brain is an incredibly complex, unfathomably delicate electrical grid. And while today we talked almost exclusively about how to support a failing grid using chemical therapies, drugs, and ventilators, I want to leave you with a provocative thought based on where the literature is pointing.
What is truly fascinating here is the trajectory of the technology. We touched on deep brain stimulation, DBS, which is currently used as an implanted pacemaker in the basal ganglia to override the abnormal circuitry of Parkinson's tremors. We use implanted vagal nerve stimulators that detect tachycardia and fire electrical impulses to abort seizures before they generalize.
Exactly. As we rapidly map genetic mutations like the HTT gene in Huntington's, and as biomedical engineering creates more advanced responsive neurostimulators that can read and interpret continuous EEG waves in real time, are we rapidly moving toward an era where the ICU won't just chemically sedate and support failing physiology? Will you, the ICU nurse of the near future, be actively and directly reprogramming the brain's electrical grid from a tablet at the bedside? Will you deliver targeted electrical neuromodulation to instantly reverse a coma, abort a myasthenic crisis, or stop status epilepticus without ever pushing a drop of lorazepam?
It raises an incredible question about the future of our profession. The monumental leap from blunt chemical management to precise, direct electrical neuromodulation isn't science fiction. The trials are happening right now.
Something heavy for you to ponder during your next night shift. Thanks for joining us on this intense deep dive into the neurologic critical care landscape. Keep pushing your clinical reasoning, keep questioning the why behind every order, and we'll see you on the next deep dive.